Hello, everyone. My name is Miguel Perales. I'm the chief of the Blood and Marrow Transplant Service at Memorial Sloan Kettering in New York. Today, I will be talking about a presentation I gave at the EBMT Presidential Symposium last week in Prague. The topic of my presentation is the impact of checkpoint inhibitors in patients undergoing an allogeneic stem cell transplant for Hodgkin's disease. As you know, there have been dramatic changes in the management of patients with Hodgkin's lymphoma over the last decade or so, particularly with the introduction of new therapies such as rituximab vedotin or checkpoint inhibitors. And Hodgkin's disease has proven to be particularly sensitive to the use of drugs like nivolumab or pembrolizumab, which have dramatically changed how we manage these patients. As a result of this, we've seen a significant reduction in the use of allogeneic transplants for these patients. However, when we look at historic data, particularly data from the EBMT that has been published by Anna Sureda, you can see that the number of transplants has gone down, but the results of the transplants, allogeneic transplants in patients with Hodgkin lymphoma, has actually improved. So one other question is, what is driving this improvement? We know that there are obviously changes in management of patients and donor selection, but we should also look at the impact of new drugs. We know that the era of rituximab has changed the management of patients with Hodgkin lymphoma and resulted in better outcomes. And when we looked at historical data of the pre-rituximab era versus more recent data in patients receiving an allogeneic stem cell transplant, we saw an improvement. However, in another EBMT study, it was shown that this was not related to prior rituximab exposure. So the question we asked in this study, which was a joint CIBMTR and EBMT study, was what happened to patients who had received prior checkpoint inhibitors and then proceeded to allogeneic transplant. The study included over 1,400 patients, and about 400 patients received a prior checkpoint inhibitor and the remainder hadn't. The study included patients over the age of 18 with Hodgkin's lymphoma transplanted between 2008 and 2019. And when we looked at the two cohorts, what we saw were some significant differences in outcomes. In particular, the progression-free survival was significantly improved in patients who received a prior checkpoint inhibitor. And this was really due to a decrease in relapse, which again was significantly different. We did not see a significant difference in non-relapse mortality. However, overall survival was similar between the two cohorts. And when we looked at other outcomes impacting overall survival, typical outcomes that you would see, or factors that you would see included age of the patient, use of reduced intensity versus myeloablative transplant, as well as the performance status of the patient. Other factors that were influenced by prior checkpoint inhibition, which I'll note, are the fact that there was an increased risk of acute graft versus host disease, but no impact on severe graft versus host disease or chronic GVHD. So what do these results tell us? The main point I'd like to make is that, number one, the transplant in patients who received prior checkpoint inhibition is safe, that there is no impact on overall survival. We know that the drugs appear to have an effect even post-transplant, probably through an impact on the immune system of the donor and so-called graft versus lymphoma effect, since we see significant differences in relapse and progression-free survival. We also see an impact on acute GVHD, although this does not seem to translate in worse non-relapse mortality. I think that we have a treatment approach which can be curative in patients with Hodgkin's lymphoma. And while the number of transplants has decreased significantly because we have better non-transplant options for these patients, given the fact that the median age of a patient with Hodgkin's lymphoma is around 32, I think we should continue to offer this curative treatment for these patients when appropriate. In my own practice, I consider that patients who are progressing on a checkpoint inhibitor, who have a poor response to the checkpoint inhibitor, should be referred for an allogeneic transplant. The ideal time to wait, based on published data from Reed Merriman from multi-center cohort, is 80 days between checkpoint inhibition and proceeding to transplant. But in many cases, that's not possible. For GVHD prophylaxis, we have turned to using post-transplant cyclophosphamide in all patients, regardless of graft source, whether it be a matched sibling donor, matched unrelated donor, or mismatched donor. It's also a question we asked in our series to see if the GVHD prophylaxis had an impact, but we were underpowered to look at that. But I think, importantly, the results are excellent, and we continue to offer curative treatment for our patients. Thank you very much for your attention.